I'm Dr. Alexey Danielov, professor in the Department of Hematology at City of Hope National Medical Center in Los Angeles. And we are coming to you virtually from ASH 2023 annual meeting. And I'm joined here by Dr. Ben Heyman, who I invite to introduce himself.
Thank you so much for having me. My name is Dr. Benjamin Heyman. I'm an associate professor at UC San Diego, hematologist, and it's a great pleasure to be able to talk with you to a little bit of the research that I was part of that was presented at the American Society of Hematology 2023 meeting.
Thank you, Dr. Heyman, again for joining us here. And let's talk about your presentation, a long-term analysis of lenalidomide and rituximab, or R squared, for treatment of CLL. What can you tell us about your data?
Sure. Yeah, so this was a long-term analysis of two studies that were performed over a decade ago as part of the CLL Research Consortium. One of the studies, the first study was in patients with treatment-naive CLL, and then the second study was in relapse refractory CLL. So this was kind of a 10-year follow-up to look at kind of long-term data. And so I think the reason we wanted to do this analysis really was because I think there is some interest in looking at kind of, while certainly the targeted therapies for patients with CLL have really kind of come back, have really taken over the treatment for CLL. We wanted to look a little bit more back in lenalidomide now, because there is a big, as you know so much, there's a big focus on using immunotherapies for patients with CLL. And so we wanted to see, and given the immunomodulatory properties of lenalidomide, we wanted to kind of take a look at this once again and see does it have a potential to maybe have some type of comeback in future strategies for CLL again. And so we looked at this kind of 10-year follow-up of two different studies. The first was about 45 patients with treatment-naive CLL. The study design was that we know patients had a kind of a slow ramp up of their lenalidomide. We know patients with CLL can have kind of tumor flare, of their CLL. So they had a slow ramp up from 2.5 milligrams to about 10 milligrams over their first cycle of treatment over the course of several weeks. And then at the end of that first cycle, they began to be administered rituximab. And then they got to a maximum dose of lenalidomide of 10 milligrams. And then they received kind of combination lenalidomide and rituximab over the course of essentially 6 months. So their total treatment was about 7 months of treatment. In the relapse refractory study design, it was a little different. Patients started at a dose of 5 milligrams, again, slowly ramped up to try to potentially mitigate the risk of tumor flare, and could eventually go up to a higher dose of 25 milligrams. And whatever dose the patients could tolerate that didn't cause a maximum flare, again, was the maximum dose. And also in the relapse refractory setting, they started rituximab started right away, as opposed to having this delayed rituximab. And in the relapse refractory setting, patients had the option after completing 6 months of lenalidomide that they could go on to a lenalidomide maintenance. They could continue lenalidomide if they had a good response initially. If we looked at the patient characteristics for this study, in both the treatment naive as well as the relapse refractory cohorts, most patients had a kind of advanced stage RI disease. Most of them had a kind of stage 3 or stage 4 RI disease. Back then we didn't have, this was an older study, but we did have a fairly robust kind of cytogenetic profile. The most common kind of cytogenetic changes we saw that were kind of in with deletion 13q, but there was a significant portion, about 10% of patients did have deletion 17p, and about less than 5% had complex karyotypes. For the patients that we did have data on, about 70% of them harbored an unmutated immunoglobular heavy chain. We didn't have really much next generation sequencing at all. Back of course, this was done over 10 years ago. And so if we kind of look at our overall kind of responses, what we see for both cohorts, we did see kind of low responses of complete responses, which not unexpected if we look kind of now historically back at what we've seen with lenalidomide and rituximab, but about 10 to 15% of patients achieved a complete response. But if we looked at kind of the overall response, we did see kind of higher overall response rates. Approximately 2/3 of patients, about 2/3 of 70% of patients had an overall response, and very few patients had progressive disease on treatment. Only about 1 to 2% of patients had progressive disease on treatment. We were able to evaluate multiparametric MRD analysis by multiparametric flow cytometry. This was performed by bone marrow biopsy samples after completion of the initial 6-month timeframes, initial induction 6-month period for patients, and no patients after 6 months, either in the treatment naive or in the relapse refractory setting, achieved kind of undetectable MRD with this treatment regimen.
But that is not surprising, right?
Correct, right. We're not getting deep responses with this regimen. Correct.
Yeah, but so it sounds like the regimen was highly effective overall. It sounds like ultimately few patients progressed on treatment, right? So what was the reason why patients? What were the reasons why patients came off study, stopped the treatment?
Yeah, so in the treatment naive, it was 6 months per protocol.
Yeah.
And then in the relapse refractory setting, there were patients who responded, continued on len maintenance, and we did see that there was actually a differential PFS benefit in that setting. So for patients in the relapse refractory setting, they actually had improved PFS compared to the treatment naive, which we think was because of that kind of len maintenance arm overall comparatively. I think the one thing that we did find, which was interesting, I think Revlimid lost kind of its, never moved forward in CLL because of this concern for toxicity. And the one interesting finding we did find in this 10-year follow-up is that we didn't really see, when we looked at kind of toxicity, we didn't really see there was not any increase of, there were no kind of venous thromboembolism that occurred on study for patients. The only two that occurred kind of after study were in patients who had not been taking aspirin appropriately, so had not been on appropriate thromboprophylaxis. We didn't necessarily see any kind of really treatment-related mortality related to studied drugs. Most of the patients who eventually died in the long-term follow-up was either related to CLL or not, to other natural causes, not related to potentially to study treatment. Didn't necessarily see kind of an increased kind of significant infectious complications either. Those were kind of all the major signals that we were always concerned about with Revlimid that eventually led to kind of its regulatory demise. So I think certainly we didn't see such a significant kind of risk necessarily that in general. So with this combination.
And of course, in relapse setting, when this study was done, none of these patients had received BTK inhibitors, right? So how do you think the results would compare in today's landscape when patients are treated with ibrutinib and venetoclax or similar BTK inhibitors?
Yeah, I think prior to the approval of pirtobrutinib and I think prior to I think certainly without clinical trial options for patients, right? I think those patients who were refractory to both BTK and venetoclax, right, there weren't many options available to them. So certainly if you were going for kind of a non-clinical trial, or certainly I think sometimes would think about could we give lenalidomide or PI3 kinase inhibitor for patients in those settings. Now certainly with the approval of pirtobrutinib and things like that, certainly this would not be something that we would think about for patients. But I think there could it be potentially when we think about reinvigorating kind of immunotherapy for patients with CLL, things like combinations with bispecific antibodies, CAR T-cell therapy. Can these potentially be options that you would think about potentially combining it with it? We worry about patients with CLL, their T cells not functioning well, and that can essentially limit their responses to immunotherapy. We know that lenalidomide as an immunomodulator can potentially improve kind of T cell function, and so could that potentially be one way to think of it as a combination strategy to potentially help improve or augment those novel kind of immunotherapies? So. I think the promising safety signal, I think, might kind of lend some credence that this might be something that we potentially could look to as well.
Yeah, very exciting. And I agree with you. It would be, certainly in other lymphomas and B-cell non-Hodgkin lymphomas, we talk about targeted therapies sensitizing to CAR T-cell therapies or bispecific antibodies or potentially mitigating some adverse events. Of course, the problem we have in CLL, neither CAR T-cell nor bispecific antibodies are approved, or they at least CAR T-cells in my mind have some issues, right, in CLL. So, but maybe exactly that's what we need. Reinvigoration of the immune system might potentially mitigate all this immune deficiencies that we see post CAR T in CLL. So that could be one interesting study. Maybe we should think about.
Sounds like a great idea. Sounds like a good idea. Yeah, yeah. So yeah, that was one reason we kind of wanted to look at this, was saying,
Yeah,
how
no,
potentially we could look at that. So
and
yeah.
certainly encouraging you are not seeing any like long-term toxicities.
Correct, correct. Right.
Yeah,
And that was always the big concern with lenalidomide CLL, is the safety. And at least
yeah.
we at least in our 65 patients, we are not seeing that big risk in general.
Okay, okay, exciting. Very, very, very helpful data for the CLL community. Thank you so much, Dr. Heyman, for sharing it with us.
Thank you.